Welcome to your second monthly update on the COVIDENCE UK study. My name is Adrian Martineau. I'm Professor of Respiratory Infection at Queen Mary University of London, and I'm leading the research project. Today we have 3 interviews for you, the first of which is with my colleague Professor David McCoy, who will talk about the chances of a second wave of COVID this winter. Second, we'll be talking to Dr. Katie Young, who's a lecturer in psychology at King's College London. She's been analysing the data that you've been giving us on mental health and COVID. And thirdly, we'll be talking to Dr. Paul Pfeffer, who's a consultant respiratory physician at Barts Health NHS Trust, who's running clinics for people who are experiencing long-term symptoms of COVID-19. But before we get on to that, I'm going to hand you over to the principal investigator, Hayley Holt, for an update on recruitment and follow-up. Hayley.
Hi guys. So I'm just going to share my screen with you all. So first I'd like to give a little update on how recruitment has been going. Since the last webinar, we've had over 4,000 more participants who have completed sign up. And we've also been featured in The Guardian and the Edinburgh Evening News. So recruitment is going very well and growing steadily. I'd like to touch a little bit on the monthly questionnaire. So for the first questionnaire, we had 6,785 people invited to complete, and 6,668 people completed the questionnaire, which is a 98% completion rate, which is a fantastic number, a very high response rate, which just shows the commitment that you all have to the study, and we are really, really grateful for your participation. Within the monthly questionnaire, we asked a question about how did you guys hear about us? And this is what you had to say. And one of the most common answers was that you heard about the study from a friend or family member. So this just highlights the importance for us about you guys telling your friends and family if they would like to be involved. And one way for you to do so is we have posters that have been created for us by FutureNet Publishing. And if you would like a copy of a poster to put up in your community or hometown, we'd be happy to mail those to you. So please just email us at covidence@qmul.ac.uk if you would like a poster mailed out to you. Alternatively, on our website, there'll be downloadable versions of these posters and others that you'll be able to use if you just like to print them yourselves. And with that, Adrian, send it back to you.
Thanks very much, Hayley. And I'd just like to underline really the fantastic response rate. I've never done a study which had a 98% response rate to the first follow-up questionnaire. So thank you all for completing the follow-ups, and please continue to do so. So moving on now with the first interview of the webinar, I caught up with Professor David McCoy, who is a Professor of Global Health at Queen Mary University of London. David's got a lot of international experience in infectious disease management, having worked for 10 years in South Africa and also working as a Director of Public Health in London as well. And I caught up with him and asked him, first of all, about what his assessment is of the chances of the UK experiencing a second wave of coronavirus disease later this year. David, it feels like this pandemic's almost over. Shops are open again. Groups of up to 6 people can meet up outdoors. How do you think things will play out from here? And what are the chances of a second wave?
So things are definitely not over. We still have circulating virus in the community. We probably there are probably about 4,000 new infections a day presently. But what will happen in the future is still unclear. At the moment, we seem to have seen a leveling off of the new infections, new hospitalizations. In other words, the decline that we started to see from about April onwards has stopped declining. New cases haven't necessarily gone up, they've just been leveled off. And we're not really sure what will exactly happen over the next few weeks. We're going to have to wait and see. Certainly there's much more mixing in the population and much more chances of the virus being transmitted. At the same time, we know that there are some changes that have happened in the population. There will be a degree of population level immunity that may help to kind of limit transmission rates. And we do have perhaps a greater degree of ability to suppress local outbreaks than we had 3 or 4 months ago, although that ability is not as good as it used to be. And there is still continued physical distancing. Lots of school children are still at home. So exactly what will happen over the next few months, particularly during the summer, is unclear. My guess is that we will not see a second wave over the next 2 or 3 months, but certainly by the time we come to the autumn and the winter, where there is a high risk of infections being transmitted in the population, that we may start to see a generalized rise in new infections and new cases.
Thank you. Can you just give us your opinion about why autumn and winter might be a particularly risky period?
So it does seem like coronavirus, we know from the past that coronavirus has a kind of seasonal pattern to it, with infections being more transmissible during the winter months for a number of reasons, people crowding together indoors much more than they would in the summer months. And there may be something about changes in the temperature and humidity in the air that also contributes to this kind of seasonal pattern.
Got it. I wonder if you could give us your views on what public health policy should now be pursued to avoid a second wave, or at least to minimise its impact.
Well, the main thing is to be able to do very proactive case detection, and that will be done both through a mixture of testing, but also picking up people who are symptomatic or have signs of potential coronavirus infection, being able to detect them quickly, being able to implement contact tracing so that we can kind of keep a lid on any local or new outbreaks, kind of becoming bigger outbreaks and turning into a more generalized epidemic. So that would be the main thing. The two other things would be to continue with physical distancing. So although we've had a loosening of lockdown, we do need to continue with the current guidance around maintaining some physical distancing. And I think the second issue is really about paying attention not just to new infections, but paying attention to new infections that are likely to be severe, and that might result in a premature death. So that means keeping our eye on shielding and ensuring that people with risk factors take extra precautions in preventing themselves from being infected.
Thanks, Dave. It's clear that approaches to disease control have varied quite a lot between different countries. I wonder what you think are the main things we can learn from making international comparisons about how different countries have fared.
I would say the UK's got 2 or 3 things to learn from the international experience. I think the first thing is really recognizing the importance of the human dimension to all of this. The management of coronavirus in terms of preventing transmission requires all kinds of behavioral changes in the public. And this really emphasizes the kind of social, cultural aspects of disease control and being able to communicate and being able to inform people about the virus is a very human, a human aspect to disease control. So even those countries like Singapore, Taiwan, and South Korea, which have been recognized as having managed to successfully control transmission through the use of technology, you will actually see that they placed a huge amount of tension on the human dimension. There was a lot of human-to-human communication, and that's something that I think we've perhaps underestimated or undervalued in the UK. The second thing would be decentralization. Many of the countries have recognized that you need to respond to this epidemic in different ways in different parts of the country. Being able to take into account contextual factors, being able to take into account the specific transmission dynamics of different parts of the country and tailoring your disease control plan accordingly. And then the third and perhaps final thing is recognizing the importance of political leadership. Those countries that have done well, I think, have demonstrated really sound political leadership and a form of political leadership that has enabled experts, public health experts, to also take an appropriate lead in designing managing and implementing the disease control plans.
Thank you. I did have just one more question. Sorry, I said the last one was the final one, but as you know, this interview's going into the webinar for the COVIDENCE UK participants. I wonder if you could just share with us what insights you're hoping to gain from the COVIDENCE UK study, and why do you think it's important that people sign up?
Well, I think this study will help us develop a better picture of the natural history of the disease, and it will help us to kind of determine what the relationship between a variety of risk factors is with both getting infection but also getting a severe form of the infection. And this is one of the great kind of mysteries of COVID, is trying to determine why it is that some people get a very severe infection and other people seem to be able to cope with only a mild infection. So the more people that we can get recruited onto this study, the better, in terms of basically improving our knowledge and understanding of the natural history of this disease.
Well, thanks very much for joining us today, David, and for your valuable insights.
My pleasure.
We now move from public health to mental health. Dr. Katie Young is a lecturer in psychology at King's College London, and she's been looking at data from the COVIDENCE UK study relating to the impact of the pandemic on participants' mental health.
So yes, thanks very much for having me. I'm excited to be talking to you today about some of our really early findings looking at the mental health during the COVID-19 pandemic. And so I'm going to be sharing with you some early data from the COVIDENCE study. And I'm also going to be talking a little bit about another study we're running, a study called RAMP, which is the Repeated Assessment of Mental Health in Pandemics. It's also an online questionnaire-based study, but focusing more on the mental health side than the physical health side, so quite complementary to what's happening. So in terms of mental health research, we know that stress is very much linked to depression and anxiety. Periods of stress are well known to have an impact on mental health, and we see a large association really between stressful life experiences and more persistent symptoms of depression and anxiety. And of course, the stress that we're experiencing in the COVID-19 pandemic is very unusual. It's not something that we have experienced before. So in addition to the concerns around COVID-19 and the infection, actually all the measures introduced to control the virus have had a big impact on our daily lives, as we know, affecting a lot of other areas that might also contribute to our mental well-being. So most prominently, of course, there's higher levels of worries and concerns at the moment. So obviously about the risk of contracting COVID-19 and health of friends and families. This is a big predictor of subsequent anxiety problems. There are other stressors as well. As we know, there's been huge disruption to education and employment through the furlough scheme and a lot of uncertainty around employment, bringing in additional stressors around perhaps financial stability and employment stability as well. So that's an additional kind of stressor at the moment. At the same time, various aspects that we know typically help to protect our mental well-being have also been impacted. So one area particularly is social support. We know that one of the best things to kind of buffer the effects of stress on depression is having supportive people, the sort of social support that you can rely on, friends and family to talk to. So changes obviously to the types of social interactions we're having with social distancing might be playing a role there as well. And similarly for access to recreational activities, so the sorts of hobbies and pastimes that people often engage with that we know to be sort of helpful for mental well-being. Reduced access to those types of things might also be a contributing factor. So there's a lot more going on than just the worry around the virus itself, which might be having an impact on mental health. So across both of our studies, we're aiming to assess the impact of the pandemic on mental well-being, to try and understand who's most at risk and use this to help inform support both from a sort of health perspective and a social care perspective as well. So throughout the rest of the slides, I'm going to be doing a little bit of a comparison between our RAMP study and the COVIDENCE study. So I thought I'd just show you a little bit of a comparison in terms of who's in each of these studies. So with the data I've been looking at so far, we actually have pretty similar numbers of participants. But these are plots showing the age breakdown across the sample. So just the numbers of participants in each of these different age groups. And you can see that in RAMP, we have a sort of younger sample overall. So higher bars over here on the left in the younger age groups than compared to the COVIDENCE study. So when I'm sort of showing you the results as we go, that's something to bear in mind. Also just looking quickly at the gender breakdown across studies, because I'll show some data later, breakdown by gender. And so in RAMP, we have around 78% female participants. It's a little more balanced in COVIDENCE. You have 70% female and 30% male. This is very typical, actually, of a lot of research, but particularly online research, we tend to really highly predominantly female samples. So again, just something to bear in mind as we go. So this is something just from the RAMP study, just as a bit of an introduction. So in RAMP, we're asking a lot of questions about mental health. And one of the things that we do is that we ask people, fairly long questionnaires about symptoms of anxiety and symptoms of depression. After they participants complete these questionnaires, we ask them, how much do you feel like your symptoms have changed since before the pandemic? So very simple one, asking people if they think their symptoms are better than before, or if there's no change, or if they're worse. And you can see in this plot, so the inner ring here is symptoms of depression and the outer ring is symptoms of anxiety. It's quite a strikingly high proportion of people are saying that their symptoms, or percent of people, are experiencing worsened mental health since the pandemic. 20 to 25%. And a small proportion of people actually saying that their symptoms are improved right now. So it gives us a sort of initial snapshot into how people feel that their mental health has been affected. So quite a striking, large sample, as I mentioned. Now just starting to look across age. So this is RAMP study data here on the left and COVIDENCE study data here on the right. You'll see that the scales on these plots are a little bit different. That's because we've used slightly different measures across the two studies. So the overall height of the bar doesn't mean too much here, but what we're looking at instead is the difference across age. And you can see that in both studies, we see this kind of quite striking effect by age, where younger people are reporting higher levels of anxiety compared to older people. So we see that both in RAMP and also in the COVIDENCE study. So a fairly robust finding that younger people seem to be worse affected. And a very similar pattern is also true for symptoms of depression. So this is the same thing now, just looking at symptoms of depression rather than symptoms of anxiety. There's a few different things that we think might be playing a role here. First, we know in general, even before the pandemic, that younger people are at elevated risk for anxiety and depression. So we tend to see higher levels of symptoms in younger people anyway. But this is also true during the pandemic. And as I mentioned, there's a few different stresses that might be having a particular impact on younger people, particularly around education and unstable employment might be a sort of particular stressor for the younger compared to the older age groups. Now just breaking this down additionally by gender. So we see the same age effect across the sample here, but here in the RAMP sample, this is symptoms of anxiety, we see maybe a small difference, but a fairly marginal difference in terms of anxiety symptoms between female and male participants. But obviously that age effect is still present. In the COVIDENCE study, however, we do seem to be seeing quite a striking gender difference in terms of levels of anxiety. So the darker bars here being female participants and the lighter bars are the male participants, we see higher levels of symptoms of anxiety in women compared to men. And that's quite often a finding in mental health research, is we do typically see higher levels of anxiety in women compared to men. Perhaps not quite as large a difference here. So there's definitely something interesting for us to try and unpack in terms of what might be the difference between our two studies, what might be driving this gender difference, particularly that we see in the COVIDENCE sample. This is the same plot now, but for symptoms of depression, and you'll see that here actually we have very little gender difference in either sample. So again, a little bit surprising in that we often see higher levels of symptoms of depression in women compared to men as well. But at the moment, it seems that there's maybe a very small effect, but certainly not the sort of striking effect that we saw in terms of symptoms of anxiety. So suggesting that there's maybe something different happening in terms of symptoms of anxiety, things to do with worries and your ability to control worries, that's different to the sort of low mood symptoms of depression that we're seeing. One last just little snippet I wanted to show you. So this is data now just from the RAMP study, where we have quite a lot of information about people's existing mental health diagnoses. So any diagnoses that they had before the pandemic. So the rings in the middle here are people who did not have any previous diagnosis of anxiety or depression. And the rings on the outside are people who did have a diagnosis before the pandemic. And so these are the same plots of whether people's symptoms are worse, whether there's no change, or whether they're better. And you can see that those who do have or did have diagnoses before the pandemic, more people are reporting a worsening of their symptoms than people who didn't. So obviously still a large number of people who are saying that they are experiencing worsening anxiety and also depression, but it does seem to be a stronger effect amongst people who were already experiencing these conditions. So a lot more to come. There's a lot more to unpack here, obviously. We'd be very interested to look at the differences amongst people who have experienced symptoms of COVID or have had tests for COVID, to see whether there are particular differences amongst those groups. And we've been collecting data over time as well. So we've been collecting questionnaire data every 2 weeks. In the RAMP study, and we doing repeated assessments in the COVIDENCE study as well. So it'd be really interesting to start to understand how these things are changing as the pandemic develops. So thanks very much for listening.
Thank you very much for that, Katie, and we look forward to results of further analyses linking data on incidence of COVID to mental health outcomes in the future. Now, many of you have written in to us with questions about potential long-term symptoms of COVID-19. And in order to address that issue, I've arranged an interview with Dr. Paul Pfeffer, who's a consultant respiratory physician at Barts Health NHS Trust, where he leads clinics where patients are seen following hospital admission for COVID-19. So with us today is Dr. Paul Pfeffer, who's a consultant respiratory physician and senior lecturer in respiratory medicine at Queen Mary University of London. And he's leading on follow-up of post-COVID patients at Barts Health NHS Trust. Paul, thanks for joining the webinar today. First of all, can you tell us how commonly do people get long-term symptoms of COVID-19?
So most patients get better. We know it takes a few weeks for most patients who have had COVID in the community to get better. What we're concerned about is the significant number of people in the community and also patients who have been in hospital who are not getting better as fast as we're expecting. This is really a new disease, so trying to say what is the normal trajectory of recovery is very hard to say. What we can say is that we're contacting all of our patients at 12 weeks after their admission, and we're finding a very high proportion are not recovering as fast as we would have expected. We've got some patients with breathlessness and cough that persists, and we were expecting that, but we also got a large number of patients with profound fatigue and joint pains that have not yet improved by 12 weeks. We still hope that they will slowly improve, often with help, but we really don't know what the long-term picture is, which is why research is so vital.
So do you have a feeling for whether these persistent symptoms are due to the continued presence of the virus, or is it an effect of the immune system? What's your take?
We don't think it's persistence of the virus. Most of these patients, or at least on swab, have been negative before they've gone home from hospital. Most of the patients aren't reporting fever or other what we would call viral symptoms. But certainly the host immune system is likely to be playing a part. I mean, we were expecting people to be breathless, and there's a number of reasons people can be breathless after pneumonia. Some of those are inflammatory scarring of the lungs, and in other cases it's to do with what we call a breathing pattern disorder, where the mechanics of the lung get sent adrift when you're ill and take a while to reset. So in some cases we do think it to be inflammatory, and in some cases it's really what we'd call relearning of how to breathe. And similarly with fatigue, we would expect some people to be fatigued because of loss of muscle mass when you are ill with something like pneumonia. But the levels of breathlessness and fatigue are higher than we would expect. And really that's the big question at the moment in research, is how much of these current symptoms are being driven by the body's own immune and inflammatory systems. We know COVID is largely a disease of the immune response to the virus as much as the virus itself, and that seems to be the case even more so with the recovery and long-term complications.
Yes, I mean, your comments call to mind the recent trial of dexamethasone, which was shown to improve treatment outcomes, and that's an anti-inflammatory drug. So are people looking at the effects of steroids here, or any other treatments being given?
So if you've got scarring of your lungs of particular types that looks very active, yes, these patients are being given steroids, not through a clinical trial. I mean, scarring to the lungs is a known disorder called an organizing pneumonia, and there's evidence based on how to treat that. But that's only the minority of patients. The other patients, we're only really starting to discover what the complications are, and we haven't got to the stage of considering treatments yet. There are treatments that some of us have in mind that might potentially work, but really we're only just beginning to learn what we need to think about and to plan what trials we might want to do to see what treatments may help people recover.
So thinking of trials, any candidates that are being investigated at the moment?
Well, steroids are being considered, but although steroids are in many ways have benefits in this type of situation, they've also got side effects. So what we really want from a pharmacological basis is anti-inflammatory drugs that don't have the same side effects as steroids in this patient group. So potentials are anti-inflammatory macrolides, vitamin D, and antioxidants. Actually very simple treatments that we know work in other situations. And the question is whether we can repurpose this to improve COVID recovery. And then on the non-pharmacological side, physiotherapy and the right types of rehab are where really the direction of travel, both research and clinical, is focusing.
Well, I guess at the end of the day, the best way to evaluate those therapies is going to be clinical trials. And one way to contribute to those trials is if people sign up for COVIDENCE UK.
Yes, so certainly we've got to get people into trials. We need real world trials where we get real patients who are suffering from the complications in an unbiased manner, such as in COVIDENCE, and then we put them through a pathway where we can offer them clinical trials that target the right patients in a real world setting.
Well, thanks very much for joining us today, Paul. Good luck with the clinics and all the best.
Thank you very much. Bye-bye.
Paul, thank you very much for sharing your clinical insights. And that brings us to the end of this month's webinar. To summarise, we now have over 10,000 participants in COVIDENCE UK, of whom 98% are completing their follow-up questionnaires. We look forward to reaching the target of 12,000 and rerunning the analysis to find new evidence on risk factors for development of COVID-19. Until next month's webinar, goodbye, and thank you for providing your data to enhance scientific understanding of COVID-19 and its impacts. Goodbye.